Kia ora koutou, and thank you for the opportunity to address your conference. My name's Andrew Slater, and I'm the Chief Executive Officer of the National Telehealth Service and Homecare Medical here in Aotearoa, New Zealand. I think whilst virtual conferences are a fantastic opportunity to do more, I'm becoming convinced that you miss some of the upside of meeting people in person and enjoying the hospitality of overseas countries. I know in Canada at the moment, you guys are in a prolonged lockdown. Currently here in Auckland in New Zealand, we're 3 days into a 7-day short, sharp lockdown, but certainly here we've had the opportunity to enjoy a lot of freedoms that the rest of the world hasn't enjoyed as a result of our pandemic response. And so I just want to talk a little bit about the opportunity and the journey we've been here in New Zealand as we've gone through really the creation of the virtual healthcare system across the country. So just a little bit about the legacy world. So prior to 2015, what we had in the country was a number of helplines. There'd been little innovation in those helplines. There'd been system integration was lacking, and they weren't really set for the future. But one of our recognition was that the multi-channel nature of the helpline operating environment really did leave a platform for innovation. If you think about banking, a lot of the virtualization of the banking system came out of the call centers moving to multi-channel, moving to apps to deliver services. It didn't really grow out of the Main Street branches virtualizing into the community. Many of the contract environments were fee for input, but the core operating model really did provide that platform for change. So in 2015, the government embarked on a program of work to bring together and consolidate the helpline operations for the country. And this was the vision at the time. It was a concept of, if we built a national telehealth service on an open platform that was patient-centered by design and integrated deeply with the face-to-face system, it would provide a fundamental change to the way we delivered healthcare and wellness in the community. So today, these are the current services that are provided within the National Telehealth Service. So that includes smoking cessation services, our health advice service, Healthline, which has also been critical to the country's COVID response, 1737, which is a 4-digit number you can call or text 24/7 to speak to a registered counsellor, our National Poison Centre. And then we also coordinate some other services as well, including the National Bowel and Cervical Screening Programs, Pua Waitanga, which I'll talk a little bit more about, and our Whitiki Toa, which is a youth mentoring service. Whilst that's how the services look on the outside, on the inside of the organisation, what we have is we have 8 clinical teams that run 24 hours a day, 7 days a week. They're using a series of channels to deliver advice, whether that be phone, telephone, fax. In New Zealand, you can't be a health organisation unless you still deliver services on a fax, email, social, web, and then websites. And then within the service, we have some quite unique capabilities that we've really invested in. So one is our digital response centre. So what that was about was going and bringing in-house some of the concepts around nudge marketing, social media, to try and get information and connect with those that don't traditionally connect with face-to-face services. Fundamentally, we went and recruited a bunch of hipsters that used to use their powers to sell McDonald's to people, and we wanted to bring them in-house to try and change health outcomes of the nation. We also have our co-design capability, and then our impact and our ability to join up data with the wider health system to understand the impact and game changing that we're making. One of the unique environments for this model was about creating a completely different approach to commissioning of the services. So Homecare Medical is a social enterprise. We were created by 2 primary health organisations. who funded the capital to create the platform. And so the first thing was we needed a long-term contract. So it's a 10-year contract with the Crown, with multiple funding agencies across the services. It's founded on the principles of innovation, engagement with the sector, transparency, and the need to follow all of the guidelines of the Public Finance Act, which is the underpinning sort of government public sector organisation rules. However, we're not a we're a publicly funded agency. We're not a government department. So we kind of get all the benefit of government, but we are able to have the freedom to operate outside of that. The contract requires us to have really strong, independent clinical governance, and we're very fortunate we've been able to attract some of New Zealand's leading clinicians on that independent clinical governance committee. The great news is moving to this model from 8 individual helplines saved the government $100 million over 10 years. So it had a financial saving, but yet has resulted in a bigger operation, helping more people and more integrated. There's an annual planning process, there's a cross-agency service improvement board, and then there's an innovation fund. And there's the ability for the services to change over time. What we didn't want to do was lock in a whole set of virtual services that then didn't change over a 10-year period. And one of the other critical things is there's a requirement for us to open up the platform to other providers to come and tenant and use the technology and the systems and the processes to deliver their own services to the wider community. This was a key thing. It was actually founded off the Ontario Telehealth service model, which is sort of a global leader around enabling and providing system infrastructure for telehealth. One of the other things is at the end of the 10-year contract, all of the IP, all of the systems and the processes vest back to the Crown. We also have an obligation to support the wider health sector on its transformation to virtual care. So we make available all of our policies, processes, working models, configurations, etc., to enable the whole system to embark on a virtualization journey. The strategic goals for the service, so making sure that we co-design with Māori and Pacific communities, and particularly those who live in high deprivation areas. I think this is really important. It's very easy to create digital services for the worried well, or for those people that already have high access. Our goal is to be embedded in the health and social sector, where evidence-based and information-led, improve customer and staff experience through digital innovation, and ensure that we create a recognizable and trusted brand. Also, we're very focused on creating the workforce for the future. So we're working with tertiary organizations to create things like postgraduate diplomas and certificates in the virtualization of the relevant clinical craft. So our core operating model is there's 3 core platforms within the National Telehealth Service. One is a web hosting platform. The other is our interaction platform that manages and streams all of the interactions that come through. And then we've got a patient management system where all of our contacts are held and securely managed. That patient management system then interacts back with the system and the wider health system. What that lets us do is, for example, with some general practices, we can make appointments for people if we're talking to them. If we talk to you in the service on either web chat, text message, or on a phone call, what we'll do is we'll send that information back to your family doctor if you give us permission to do that, and that will become part of your core clinical record. Personally, I think one of the biggest challenges for health systems is that we've had secondary care, primary care, community care, and globally billions and billions of dollars has been spent trying to integrate those 3 systems. One of the challenges is, as we see the creation of a virtual healthcare pillar in that, is that my view is we have to lie it horizontally and use it as an integrator across that whole continuum. Because if we don't, we're going to end up by just simply creating another silo that we will spend decades trying to integrate into the future. Just to give a bit of context into size. So every day in the organization, we connect with about 4,000 people and provide them with advice, provide them with care, whether that's through our digital channels or other means. And one of the things that we're really proud of is the fact that we continue to run service improvement, but fundamentally, we're delivering very safe care. And increasingly dealing with quite risky situations and contributing to ensuring that New Zealanders who are at risk receive an emergency response. One of the interesting things about that, is one of the examples of a service we've got, is there's an app in the community that was funded by the Ministry of Health that enables people to enter a PHQ-9. If you're in that app and you enter a PHQ-9 result that may demonstrate you're at risk, you're invited to hit a button and you're immediately connected with a counsellor 24/7. I think it's great to be able to bring that kind of system integration. What I also think is great is that through that system, we were able to find multiple people last year and the year before and the year before that who were young people at high risk or in active suicide when we were able to make that connection and get them an on-the-ground response from a crisis team. I think for us, our highlights last year, so we have about 1,100 people involved in delivering the services across those 8 clinical teams. One of our key focus is making sure that we develop and strengthen our partnerships. So we have a number of on-ground providers who come and support the delivery of services on the platform. And then we're continuing to see growth across all of the services. So our mental health services, we increased their capacity and delivery by about 60% last year. We've seen an increase in the number of GP practices we support after hours. We're an organisation that's built on innovation and service delivery. So our new services that we put together last year was we stood up the government's COVID response for providing advice to people, managing close contacts and supportive contact tracing, as well as managing some of the backroom border processes. Whitiki Toa, the service that I was talking about just at the start there, which is our youth mentoring service. So this is designed to try and get ahead of the continuum. So what we're doing here is working with at-risk youth, and those at-risk youth are at risk of not finding employment or ending up with anxiety, depression. That means they can't work in the future. So we work with them earlier in the continuum of care to try and take a more prevention focus by providing them with 12 months virtual mentoring. We also have worked with one of the secondary care mental health services to put in place an intake service. So what that means is that we provide the front door triage and advice and services for their crisis service, enabling their crisis team to spend more time out in the community. We also developed a set of family violence services where we take referrals from police on the ground for low-level family violence incidents and then follow those through, as well as creating a front door family violence reporting service. Our digital services over the year, we created new websites for a new online journey for our smoking cessation service, the Cancer Control Agency, as well as PICI, which I'm going to talk a little bit more about in a tick. As well as that, we're providing some counselling services to a Royal Commission into abuse and state care. Just briefly on the COVID service, because I think health systems around the world are grappling with COVID and how it's impacted them. So what we've had here is we've had our nurse triage service. We've now got dedicated lines to support the COVID services and now run a number of services across the country. One of the key things about our services is we're able to hear what people are saying and how they're reacting. So what we're able to do is take all of those themes and messages and drive the public information and messaging that comes, and particularly the messaging that our Director General of Health and our Prime Minister, Jacinda Ardern, provide on a daily basis to the population. You can sort of see some of the volumes. So the blue line here is the demand on our service in 2019. The orange line is the demand on the service in 2020. And the green line is how we're currently tracking in 2021. So you can really see the increase in workload and the scale out that we've had to do as an organization. One of the really interesting things that we've seen here is that we've seen a move and a fundamental shift from face-to-face services to virtual services. So the yellow line there is our demand in our nurse triage service, which has really offset demand into the urgent care services across Auckland City, which really, I guess, shows and fundamentally proves that virtual services can solve people's problems and create capacity in the face-to-face system for those that need it more. And then this graph here just demonstrates the mental health and addictions workload that we've seen in the service. So the orange dotted line there is the 2019 volumes. The green is the 2020, and then the blue is where we're currently tracking. And what you can see, obviously, sadly in New Zealand, we've had a terror attack in 2019, which drove a lot of volume, and we stood up, and in fact, actually in that response, because of the online live streaming nature of that event, what we had was what we called virtual eyewitnesses in the hundreds of thousands. So actually, in the days after that event, the secondary care system put about 150 psychiatrists, psychologists, counsellors into our organisation to kind of try and lead an early intervention service. And we counselled about 28,000 people that had been virtual eyewitnesses into that event. And we're just currently actually doing some research into the impact that has had on the downstream effects on that response. Fundamentally, at the centre of everything we do is is co-design and working with communities. These are the 4 personas. These 4 personas are the result of interviewing 1,000 people at the start of the service about what they wanted out of the National Telehealth Service. They have changing needs based on technology. So, for example, Wiremu there didn't have an iPhone 5 years ago. He's now got an iPhone 6. He is really excited about his iPhone 6. Our technology team want to build for the iPhone 12, but they've got to build everything for Wiremu. These were drawn by our clinical director's 5-year-old son at the time, when we explained to him who the personas were. We paid him $5 and got the copyright, which we're very pleased to still keep. Fundamentally, we also have strong clinical governance frameworks, ensuring that we always put the person at the centre. We're providing equitable, safe care that's accessible, effective, and efficient. And bringing through the consumer voice all of the time. So, for example, we monitor and we daily talk to about 4 or 5% of the people that contact us and get feedback. We collect net promoter scores. We're very careful. So in healthcare, 80% of people are always satisfied. So we're very careful about making sure we really drive into improvement and get improvement ideas out, rather than sort of self-congratulatory processes. What we see with Net Promoter Score is it's a much more sensitive measure to change. So if we've put change in the system, we see that come through in that. These are some of the examples of how we bring through the patient voice. Every one of our internal meetings starts with a patient story. Every decision we make at a governance, board, management team layer has to articulate the impact of this decision. We've also tried to make it really easy to get feedback. So we have an online community that we can post marketing material and things up to get input from service users. These are just some of the other examples that we've got. Fundamentally, what we're trying to do here in the digital health system is get social marketing, get information out to people in their community so they can help themselves. We then run personalized, automated advice. So how can we give you information quite bespoke to you, whether that's an app, an e-therapy, a symptom checker. Then what we want to do is bring you into an online interaction, whether that's chat, email, text, or social messaging. And that's because one clinician can manage 5 of those interactions at any one time. And then a personal interaction, so phone, picture, video. The key thing there is like in all countries, there's more need than we currently have resource. So by running what we call the funnel, we're able to connect with people in the channel that's most likely to result in their problem being solved. This here's some of our social media and some of our digital response teams work. And look, we give them very clear range to go and do things. And if you look at the little advert there in the red, I'm worried if I give up smoking, I'll replace it with murdering. There is no way that in our traditional marketing sign-offs and processes that social media post would have gone out and got approval. It would have got stuck in bureaucracy and things. However, that post was one of the cheapest posts we've ever made. It was done by our in-house graphics team. It cost a couple of bucks to put up. And it resulted in one of the biggest engagements that went viral around the country and one of the biggest one-off engagements into our smoking cessation service. So it worked. And I think that that's one of the things is we've got to think quite differently as a health system, as we take on these social media platforms for actually making them get some great health outcomes. Another example of that there, which is some of the new area that we're working in, is around how do we nudge people into services that don't have them. So this particular campaign here was designed to get people that were at high risk of depression and anxiety that weren't connected with general practice to get them enrolled in brief intervention counselling. What we were able to do is using a series of different adverts that were created in those mesh blocks, which are the sort of 1 kilometre mesh blocks that the country's divided up into. What we were able to do is put those into places and then nudge youth in. And what we saw was that we were effectively able to get 747 people in a geographical area engaged, and then from there get 25% of them into those programs, fundamentally queue jumping many of the worried well who were in those GP practices accessing that really high need service before the people that were disconnected from general practice. Peer support. So this is a service that we've been running over COVID, which is putting peer support workers alongside our professional and registered counsellors and things. These people here, we had 40 variants of the advert that we also, 60 actually, that we were able to go and place across mesh blocks around the country. And what we've seen is a huge engagement with, once again, a disconnected group of people that typically would not access face-to-face services. Fi Tiki Toa, so this is the virtualization of that youth, that high needs youth service. So this is the service that's delivering, so supporting people in entering the workforce and enabling them to have a mentor that will deal with everything that they might come across as they go through that journey. Pua Waitanga, this is a service that we created a few years ago, and what it is it's a brief intervention counselling service, but it's 12 months of unlimited support. And this service receives sort of 200 to 300 referrals a week. The important thing about this was that people needed to be able to connect outside of the normal Monday to Friday counselling hours and have it from the luxury of their own home or environment. So we offer the service in about 13 languages, including New Zealand Sign Language. And what we also do here is we let people choose the counsellor that they want, and they choose their appointment time. So many of the appointments in this service are delivered in weekends and after hours. We use kind of an Uberization model. So we use mainly a contract workforce that can take on sort of piecemeal work, but you have the same mentor for 12 months. One of the really interesting things about this is we've seen phenomenal outcome measures, and particularly in our Māori population, where we're getting better outcomes than what we would have for the general population. But once we put the service through co-design with Māori, we've seen both groups and outcomes seen outcomes improve for both groups. So where are we off to in the future? Look, some reflections on the last year from me. Look, partnering with the Crown is absolutely key. Our partners are fundamentally vital to a response. The benefit of international learning, which I guess is something that we're doing here now, making sure that you don't perpetually run your organisations in incident response, One of the things, unfortunately, our IT team delivered a 5-month IT project in 7 days. So now I'm expecting that kind of cadence from them for all of our IT projects. And also the challenges around border supply chains. And so certainly some of our hardware, I think at one point we bought every webcam that you could possibly buy in New Zealand from every retail store. In terms of our system vision, so we see the creation of a digital health wellbeing ecosystem as a once in a lifetime opportunity to end inequity and connect with the unconnected. And, I just think that we as systems need to grab that opportunity and make sure we don't increase siloing, increase walls, and create that fourth sector that then requires integration into the future. We shouldn't just see digital as e-therapies. For me, it's apps, virtual care delivery, phone, social media, and text. It's actually the magic of all of those channels coming together that will give us exponential outcomes and improvements. Only co-design your new digital tools with the target audience, not representative groups. We get different answers. If we co-design a design of a tool or a design of a channel with just Māori, rather than a representative group of the population, we get different outcomes. When we design it just with Māori, we get an outcome that not only benefits them exponentially, it actually increases and gets a better result than what you'd get if you'd done the representative group. And we've done A and B testing on that. Please measure outcomes, not inputs and clicks. Use nudge marketing, not mass marketing. See digital as a product, not a project. So there's no point creating a digital thing that then requires a huge capital investment in year 3. All of these tools need agile. They need to be constantly monitored, improved, and have an ongoing improvement cycle. And my view is look, we're an inside-out enabler and transformer, not an outside-in disruptor to the system. And I think that creating entities and commissioning arrangements that are now enable the digital transformation inside out of the health sector is absolutely critical to creating a system that will get exponential outcomes. So that's all from me. I think I'll be joining you shortly to take written questions or questions on the thing. And I hope you enjoyed a little bit of an overview from what we have down under. Kia ora koutou.